Thank you, George, and good afternoon. It's just great to see so many colleagues and so many of the pioneers. I'm looking right here at Cece. Happy birthday to you. And so today I've been asked to speak about two areas, public health nutrition and emergency preparedness in nutrition and health literacy. So obviously in 20 minutes won't be possible to cover these two vast areas. So what I'd like to do, because public health tends to be kind of siloized by topics, and health literacy and good communication is something that's very cross-cutting, I'd like to start out by talking about the process involved in doing health literacy and good communication, and then move on to some of the highlights of the areas of public health nutrition and emergency preparedness. I'll first start out with a personal story. When I was asked to speak about public health nutrition and health literacy, I began to reflect that health literacy issues have actually changed the entire course of my career. And this starts out as a sad story. Many years ago, when I got my master's degree in nutrition, I began to work as a public health nutritionist. And I soon began to realize that all my great science-based messages just weren't working with my clients. So I checked in with my colleagues, and they had the same response. They said, people don't change, but it's our job to tell them what to do. So I began to think, something isn't going right here. And this morning, I think Tori Harris put it very well. She said, we have messages to put out there, and people have very different lives to live, and we're just not making that connection. So I understood that, and I decided to drop my entire public health nutrition career and set about doing something else entirely, and that was exploring just what kinds of communication could really help people promote their health. And that's still what I'm exploring. I have been working and directing the Health Research for Action Center at the School of Public Health at UC Berkeley, and we're a mix of researchers and communication people and policy folks. And we are all focused on issues of health literacy, and also very especially on participatory design, so involving the users in developing, implementing, and evaluating communication. And this is the core of what we've been doing for 20 years, with very diverse populations across many public health topics in many parts of the world. And the great learning we've had is that programs done with intensive participatory design work very well. Programs done without that usually don't work. So what I'd like to do is talk about process here. As Rima said, extract those steps. And over the years, we've developed a 7-step model that we have found to be very successful in developing good communication with a focus on health literacy. And I'll go over some of these steps. So the first step is really to define the goals of the communication and also the audiences. And by audiences here, I mean the very diverse end users with a special focus on people who have communication barriers related to literacy, language, culture, and functional and access issues, otherwise known in the past as disabilities. The next step is to set up an advisory group. We typically do this, not only include the end users, but a lot of different kinds of stakeholders. And those stakeholders can be as diverse as including researchers, policy people, providers who implement things, media, government, and so forth. And I think this is a very important step because we talked a lot this morning about what does public health mean. And an advisory group can be a microcosm of public health if you get the right people at the table those diverse users we talked about, plus all the stakeholders you need to make something successful, you have a microcosm of public health, and you have a much better chance of having a successful program. We then identify issues from formative research, and then we draft the communication using the best known principles of health literacy design. I want to draw your attention especially to number 5, because that is where I've focused a lot of my work and more intensely recently. And that is on doing usability testing, because the best known health literacy design principles can't codify everything about what makes communication understandable, engaging, motivating, and actionable. That has to be done with really strong input from the intended users of that. So my kind of proportion here would be half of it health literacy design principles and half of it usability tests. Now this step can take a while. You might have to go through a few iterations of doing usability testing, and by that I mean one-on-one interviews with groups of the intended users, including people with limited health literacy skills, and not just doing a focus group with a little bit of input. The 6th step is to concurrently co-design the implementation. You could have the greatest communication in the world, but if it's not feasible to implement, it's not going to work. So again, using that advisory committee to help with that is very useful. And then number 7 would be to evaluate, revise, and then scale up these programs into something large. And I could talk at length about ways that we should probably change the way we evaluate health communication and health literacy so that it's more oriented towards participatory design, but that's a discussion for another time. So with this background in mind about process, let's look at some topical areas. First, health literacy and public health nutrition programs. What do we know so far? I have not done an extensive review of the literature, but what I have seen is that there's limited information about this in the peer-reviewed research. Probably the best single article I found is one by Carbone and Zellner, a systematic review published last year, and they identified 33 studies. And most of those studies were related to measurement, development, readability, and assessing patients' individual health literacy skills. So you can see that the current literature actually leaves out quite a bit. It does not usually cover the broader factors in health literacy that we'd like to know about. Also, we need more experimental studies to show if these programs are actually moving the needle, if they're actually effective in individual health system and community contexts. In terms of oral health literacy or interactive health literacy, there is some research showing that nutritionists and dietitians are interested in health literacy, that they would like to have training and get better communication skills, but most of them are not getting this. And as many of you said this morning, if that is not a requirement of licensing, it probably won't happen very fast. So that's the direction we need to go in nutrition, as well as all the other health professions. And then there's very little information to date on sort of the environmental look in the way that Rima Rudd would, the perspective that Rima Rudd would have about what is happening actually in the community context, other contexts about health literate organizations, health literate communities. We need to get to that point. One of the studies that the systematic review pointed out was one that I'd done about 6 years ago. As a reform nutritionist, I was very curious about MyPyramidgov. And I wanted to see whether it adheres to health literacy principles. So I and my team took a look at it. And what we found was that although the readability of the site had been planned to be about 7th to 8th grade, it really varied widely when looking at the content between grade 7 and above the college level. There was a notable lack of cultural relevance, which was very important for a public health perspective, a lack of statements about family and community contexts, and it only met 50% of the Department of Health and Human Services web usability criteria, even though those had been out for a while, so I was quite surprised about that. Being curious and a reformed nutritionist, I decided to call up the USDA and find out, actually, how did they do this? So what I found out was that the site content was written by professional nutritionists, people like me who had failed, so I thought, aha. The other thing was that although it had been tested with racially and ethnically diverse people, they did not select people specifically who would maybe test at the lower half of health literacy skills, and they also had a number of college students doing it. This is not unusual, but I wanted to underscore this as something I've found in just about everything I've looked at in public health. My group does a lot of work redoing communications for other groups. And a core problem is they were never tested with the end users that are expected to make use of them. So I found all this quite interesting, and in my dreamland I thought, gee, what if I could have been there doing usability testing on the icon? What would I have found out? Several years later, I got my wish. We'll get to that in a minute. I wanted to point out an example of a very successful public health nutrition intervention. And this is the First 5 California Kit for New Parents. This is a kit that goes out to 400,000 people, 400,000 families every year in California. And it was, you can see that there's a number of, it's a multimedia kit. It has videos, it has printed material, including a guide that we developed, what to do when your child gets sick from the IHA, thank you very much, and a variety of other materials. What I wanted to point out about this project that started in 2000 is intensely user designed with diverse audiences and stakeholders thinking about all of the implementation issues, multilingual readability around the 6th to 8th grade. I led the evaluation project to look at the impact of this, and it was really quite amazing to see very significant increases just within 6 weeks of people using this on their knowledge and on their practices, including nutrition practices, infant feeding and the like. And I'll just point out one kind of surprising thing about this. In the literature, this is the only time I have ever seen this happen. So we often think about health inequities like knowledge gaps between different groups and how those tend to widen. When we started this work and we looked at Spanish speakers, they had 1/3 less knowledge about parenting practices than did English speakers. We found out that 6 weeks after receiving a kit, those Spanish speakers completely erased the knowledge gap compared with English speakers who had not yet gotten a kit. I have never seen that happen, but I think it shows that if you really design something well with health literacy principles and intensive user design, you are going to be able to get good results in a public health perspective. You can move the needle. This is a large program, 400,000 people a year. This has also been adapted to 4 other states and overseas. I'm currently working in Australia to adapt this model with those 7 steps there. There's a number of other examples we could look at. The California Network for Healthy California, they have some good information there. We don't often think about the U.S. Food and Drug Administration as a public health main source of public health nutrition information, but they actually do a lot. Food safety alerts, information about nutrition and health in a lot of their different centers. And in 2008, I was a founding member of their Risk Communication Advisory Committee, and we set up a lot of ways to improve the very hard to understand information there. Also, we don't often think about pharmaceutical companies as a public health source of information, but when you think about it, they can target people with nutrition-related diseases, diabetes, hypertension. If they do well, others do well. A few years ago, I had the pleasure of working with the Eli Lilly Company to take this before example of a booklet. This is part of a booklet on healthy eating, and work very intensely with users to transform that into something they wanted. And so you can see the icon, which none of them understood, and the hand things there, which they thought were kind of abstract. And they turned it into this using the new My Plate, and you can see that this is a good example of adhering to health literacy principles, lots of white space, simple language, taking the hand measurements and then pairing those with pictures. And so for a number of these participants, they said, that's the first time I understood what a serving size was. And they had to really come up with it there. I want to say a few things about health literacy and emergency preparedness communication. I've been doing a CDC-funded project for the last 5 years, and I can say briefly that there's not much information about health literacy issues and emergency preparedness. There was a study by Friedman and colleagues testing 50 websites, and they found that, of course, the readability was quite high, the SAM scores were quite low, and no studies of availability of communication in a geographic area. We know that vulnerable populations are extremely high risk for death and injury during disasters, and some of those include older adults. And I wanted to specifically focus for a few minutes on a group that is largely overlooked in our society, and that is the 48 million people who are deaf or hard of hearing. And the recommended reading level for information for them is the 3rd to 4th grade. So we wanted to see how well emergency preparedness communications were doing. Just a comment or two about people who are deaf and hard of hearing. There are many, many subgroups in this area, in this population. Many members of the deaf community itself don't identify as being disabled, but as being a minority linguistic group. They use American Sign Language and other forms of communication, but ASL does not directly translate into a language, such as English. It's a gestural 3D language, and there's no exact mix. Members of the deaf community, as I mentioned, have low literacy, so they need materials at low reading levels, and they need information in ASL video formats. So when we think about interactive health literacy or oral health literacy, we have to completely rethink this for the deaf population, because non-hearing populations have to have a different way to interact. However, we don't have any health literacy standards yet for video formats. That's something I'm working on with my group and others of us. So in our study, we examined all of the state emergency operations plans in the U.S. and the territories. We looked at availability of emergency preparedness materials for older adults and people who are deaf and hard of hearing in one county to see about availability. Assessed readability, did interviews and focus groups. Just wanted to point out the team it took to do this at Berkeley. We spent 6 months combing the entire country for the best advisory board we could find that had researchers, policy people, technology folks, community people, all kinds of representatives of different subgroups of people who are deaf and hard of hearing. Here's our first meeting. So what did we find? We found that only 1/3 of state plans even mentioned people who are deaf and hard of hearing, and no specific plans about what to do for them. Less than half of the community organizations in our county of 1 million people even had emergency preparedness materials for these populations. None of those materials met the standard of maximum of 4th grade reading level. The lowest was 7th grade, and most were above the 10th grade. And we found that the vast majority of service providers want what they said, plain language materials, and that first responders need to know how to do interactive communication with people who are deaf and hard of hearing. So to finish, some of the recommendations we got with our esteemed advisory group and through the research process here were that we need to provide national guidance to improve the U.S. state emergency operations plans, to inform Department of Homeland Security, FEMA, and the like, legislate standards for alerts, and develop better emergency preparedness materials. And as I mentioned, we have to adhere to health literacy principles. We have to make new inroads to find out what could be criteria for video formats. And then, as somebody mentioned this morning, take advantage of all the new technology that deaf and hard of hearing people are already using, and do trainings. So in conclusion, we have a long ways to go, and I would just suggest that using that 7-step highly participatory process is one that really works no matter what the topic or population. Thank you.